Newton to chair this afternoon session. So, Prof, you are welcome and we can start. Thank you.
Good afternoon, ladies and gentlemen. We'll start right away. Today we have 4 presenters, and the first one will be Benedict Apau-Ejei. This will be followed by Doris Kitson-Mills and Dennis Jesikunedu, and the last will be Irene Ajay. So the first one can come and start right away. We have 10 minutes to present, and then afterwards there will be 5 minutes of questioning. Then the second one comes in that order. Thank you.
Okay, good afternoon. My name is Benedict Apau-Ejei of the Department of Medical Imaging, and this afternoon I'm sharing with you my work that I did. The title is The Association of Blood Pressure, Body Mass Index, and Carotid Intimal Medial Thickness as Childhood Predictors of Cardiovascular Disease, a Systematic Review and Meta-Analysis. So this is going to be the outline of the presentation. So I'm sure some of you might be wondering what children and cardiovascular disease are doing in the same sentence. Because typically when you talk about cardiovascular disease, you are looking at an adult population. But then studies have shown that cardiovascular disease are the leading cause of death worldwide, accounting for about 18.5 million deaths globally. Atherosclerosis is the dominant form of cardiovascular disease, which accounts for this. When it comes to the management of cardiovascular disease, the key element is to do early diagnosis. And because of that, the American Heart Association has recommended monitoring of 4 health habits, mainly body mass, blood pressure, blood lipids, as well as blood glucose. Interestingly, childhood has been identified as an area where health behaviors directly have an impact on the risk of cardiovascular disease later on in life. Traditional risk factors for CVDs, as we know them, hypertension, diabetes, obesity, dyslipidemia, all tend to start in childhood and are carried on into adulthood. As such, early detection of children at risk of atherosclerotic disease is crucial for management and reducing advancement. But how is this early detection done? There are multiple tools that are available. Mainly, some are radiographic, which includes the carotid intimal medial thickness. The intimal medial thickness is a measure of the intimal and medial layers of the carotid artery. And this one has been chosen as a suitable tool because it is non-invasive and does not involve the use of any ionizing radiation. However, there are other childhood disease conditions that also have an effect on the intimal medial thickness, which include chronic kidney disease, familial hyperlipidemia, among others. So, the primary outcome or the aim of this study was to ascertain whether there's significant increase in the CIMT or intimal medial thickness in children with elevated blood pressure between the ages of 9 to 16 years, and also in children with increased body mass index. 9 to 16 years because apart from African settings, a lot of the countries, European and Americans, usually tend to classify people above 17 years as adults. So the age range that we used was 9 to 16 years. This, as already mentioned, was a systematic review and meta-analysis, and we did it according to the PRISMA statement. For our results, we identified 1,406 articles 97 were excluded, and in the end, we included 8 studies in this review and meta-analysis. This is the Prisma flowchart showing the various stages of elimination, culminating in the final group of studies that were included in this review. This map is to show us the geographic distribution of the included studies. One thing that jumps out at you is the fact that there are no studies coming from Africa. This is because intimal medial thickness, even though there have been studies in adults, when it comes to children, there are very few studies with regards to that. Professor Safo, one of my supervisors, has done a lot of work with regards to intimal medial thickness in adults with different health conditions. So this is the first forest plot that I would want to share with you. And this one is showing the intimal medial thickness among hypertensive and normotensive children. And from this plot, it is obvious that the intimal medial thickness is higher in hypertensive children as compared to normotensive children. The next one is showing a plot of children with high BMI and normal BMI. So showing BMI in hypertensive and normotensive children. And realize that the BMI in the hypertensive children tends to be higher than it is in the normotensive children. We looked again at the systolic blood pressure between hypertensive and normotensive children, and as expected, the systolic blood pressure is higher in hypertensives than it is in normotensives. Same with the diastolic blood pressure, which is all to be expected due to their hypertensive state. At the end, we categorized the children into overweight and normal weight based on the data that we extracted from the included studies, and realized that children who were classified as being overweight also had higher intimal medial thickness levels as compared to those who were normal weight. And then lastly, we looked at moderately obese children compared to normal weight children and came to the same conclusion that moderately obese children had higher intimal medial thickness values as compared to normal weight children. So in our discussion, from the graphs the plots that I showed, it is obvious that there's a significant difference in intimal medial thickness between hypertensives and normotensives. Children with hypertension have higher values compared to those without hypertension, as well as those in the high BMI categories. Hypertension in children with obesity was more than 10 times higher than in children with normal weight. And then we also found that if we average out all the blood pressures that were used in the studies classified as being hypertensive, it means the cutoff would be 119 over 66. 190 over 66. So any child with a blood pressure that exceeds this will be classified as a hypertensive, and they will benefit from intimal medial thickness assessment as a way of assessing their cardiovascular risk. This review goes on to underscore the need for region-specific and country-specific evaluations of cardiovascular disease risk in children using the CIMT. One thing that came up is the fact that a lot of people assume normal blood pressure to be 120 over 80, which is supposed to cut across, but that is really not the case. There are age, gender, and height-specific cutoff values that were introduced in 2017. But we would ask ourselves, is that what we are currently using in our setting? Or we are still going with 120 over 80? The same thing applies for the BMI. Previously, BMI was categorized into 3: normal weight, obese, moderately obese, or increased weight. But then now, as of 2017, they have introduced new criteria that are also gender, height, and sex and height specific. So there's no one value that cuts across all populations, and these are specific to countries. So the values that are used by Americans can't be used in an African or a Ghanaian population for that matter. Thus, there's a need for further investigation to determine appropriate thresholds for these values. That's the blood pressure values as well as the BMI values for our population. Individuals who are found to be overweight, as per the criteria that we will determine for our population, will need to also have body fat assessments. Because through this study, we also found that even though the BMI tells you the general overview of the person's weight, or the fact that the person has high levels of fat, it doesn't have the capacity to tell you the fat distribution. But then it is well known also that the distribution of the fat also has a significant role to play in the cardiovascular risk assessment. Children presenting with elevated blood pressure and BMI should be provided with the opportunity to have B-mode ultrasounds of the common carotids. In conclusion, I've already established the fact that there are significant associations between CIMT, blood pressure, and BMI in children. Children with higher blood pressure and BMI tend to have thicker CIMT values, and CIMT screening is a valuable tool that can help us in assessing cardiovascular health in childhood. Further research is, however, needed on lifestyle modifications for CIMT reversal in overweight or obese children. These are my references, and these are my acknowledgements. I'd like to thank my supervisors, Dr. Yafe, Dr. Zdonko, and Professor Fred Steven Safo, as well as two contributors that were very instrumental to the success of this work, Dr. Ijoma Anite Koko and Ms. Kataru Yaya. Thank you very much.
Thank you, Benedict. Any questions for him? Yes, the lady up there. You can come in front here. Or if there's another mic to go around.
Thank you very much for the presentation. So I wanted to ask if during your analysis you were able to find anything for underweight people, yes, with regards to the cardiovascular. Oh, sorry. So I want to find out if you found anything for any information about those who are underweight regarding the BMI for cardiovascular risk. Thank you.
Okay, so underweight people will technically fall below normal. So that means your risk of cardiovascular disease is actually very low. Yes.
So this might be oversharing, but I always get, when I do the LFTs and those things, I always get this cardiovascular risk, the value being outside the range, below the lower limit. So that is why I wanted to ask this question. Is it okay? Is it no?
So cardiovascular risk, the lab falls outside the scope of what I did. Yes.
Any other question? Yes. Please give the mic.
Thank you very much for your work. You'd realize that abdominal circumference has been recommended as a very good measure for risk of metabolic syndrome, including and that includes that also becomes a risk factor for cardiovascular diseases. In the studies that you reviewed, did you find any study that did something on abdominal circumference estimation and whether that could have also contributed to the prevalence among the children that you are getting?
Okay, so it's not just the abdominal circumference, but there's the waist circumference, the waist to hip ratio, and the likes. These are all measures that are not very specific, and even in the countries that use them, like I already mentioned, they have specific cutoffs for those countries. That cannot be generalized. So all this information is some of the issues that I hope my primary work is going to address. So in my primary work, I'm including the waist to hip ratio, and I'm introducing what is known as adiposity measurements, where you are going to use ultrasound to actually measure the fat thickness, which is going to be a more specific measure of the level of fat within the body of the child.
Okay, any other questions? Okay, thank you very much, Benedict. Okay, our next speaker is Doris Kitson Mills.
There was the first person who asked on cardiovascular risk. He said anytime you did your lipid profile, it was very high. And the lipid profile was low. Yeah, but then what will happen is that the machine calculates your total cholesterol over ADL or LDL over ADL. Now, even though you might have your lipid profile lower, but the machine will indicate that because it's a ratio, and that ratio will indicate that you are at risk. It may not necessarily be that. In any case, it may just be an heterogenic index. That means it's taking you between 10 to 15 years before this effect will manifest at all, if there's anything at all. So it just means that you need to change your lifestyle, and that is it. So once the lipid levels are not above the upper reference range, that one is just a ratio. So it may just indicate that you have cardiovascular risk. There is nothing actual to worry about.
Thank you for that education. So you have 10 minutes to present.
All right, well done, Ben. My name is Doris Kitson Mills. Greetings to you all. I'm also presenting on a systematic review and meta-analysis. I hope I don't bore you. But my focus is in low and middle income countries where we want to find out the outcomes and toxicities that is related to treatment of localized prostate cancer. So the success of this work is attributable to Drs. Yawabuya Faye, Yawampe Mamwakon, Dr. Andrew Dunker, and key experts in this field, Dr. Vena van der Poy, Dr. Enes Osebonsu, and Dr. Kofi Adeseche. So I'll be walking you through the introduction, my findings, through to acknowledgement references. As we are aware, prostate cancer is a public health concern, and the evidence shows that 1 in every 7 men will be diagnosed with this disease in their lifetime, and that's scary. And from a global perspective, from the Lancet Commission that was reported this year, in 2020, there was new cases that was recorded, it was 1.4 million, and in 2040, it's expected to double to about 3 million, and that is also scary. And the sad thing is that low and middle income countries are expected to have the highest incidence. And not only the incident, mortality will also increase because in low and middle income countries, we are having majority of cases being diagnosed at the late stage, while just very few being diagnosed at early stage. Early stages are termed localized disease, which is the focus of this systematic review, because the tumor is just confined to the prostate. And these cases tend to have improved survival because they respond well to treatment. Available treatment options that are available, that are there for this localized disease are external beam radiotherapy. We have brachytherapy, where we have a source of radiation inserted within the tumor. We have surgery. We have robotic type, and then the retropubic type. We sometimes, along with this local treatment, include hormonal treatment. But even though we have treatment for these cases and they tend to survive, the saddest thing is there are varying side effects that accompanies with. So yes, you have your treatment, you're happy, you are cured, but then this treatment poses some side effects on the patients. As these individuals tend to live, have long life, the effects of these side effects may impact their quality of life. And yes, there are evidence out there, similar systematic reviews and meta-analysis that provide evidence of this outcome, but most of these studies are from high-income countries, and the gap is that low and middle-income countries we don't have. So our aim was to synthesize the evidence on oncological outcomes and toxicities for men treated for localized prostate cancer in low and middle-income countries. And to achieve that, we focus on the oncological outcomes. With oncological outcomes, we are looking at biochemical failure rate. With biochemical failure rate, we want to mean that if a patient comes with a PSA level after treatment a year or more, we take a retest, we want the value to be less than 0.2 nanogram per milliliter. We were also looking for the prostate treatment survivor, post-treatment survivor after follow-up, and the prostate cancer specific death that the studies provided. In terms of toxicities, we're referring to the normal tissues effect responding as a result of the treatment. So we're looking at the acute and then late gastrointestinal toxicities and that of the genitourinary and skin toxicities. I might emphasize that our outcomes, we didn't really restrict ourselves, but for the purpose of this presentation, I'm just focusing on this. So what did we do? First, we built a protocol which was published in Prospero, and attached is our ID for the detailed explanation of the methodology. We follow the PRISMA guidelines. We search 3 databases, Cochrane Library, Embase, and Medline. In addition, we did the hand search as well. Terms that help us to get the right articles included prostate neoplasm terms, prostate cancer treatment, and then terms relating to low and middle income countries. We use EndNote for management of our references. And as I said, our focus on localized prostate cancer, we wanted studies from low and middle income countries, English publications, and reports specifically on outcomes and toxicities. We needed to assess the quality of the articles that we will include, so we used several of appraiser tools, and the ones we used that were convenient were the Critical Appraisal Skills Program and then the Joanna Bix Institute Specific Study Design Appraiser tool. We did a meta-analysis, and that was performed in RevBan version 4.5.4. We used a random effect model because we suspected that there's going to be heterogeneity among the studies, and our confidence interval was set at 95%. So what did we find? From the database search, we had about 2,000 hit of articles. We needed to screen this through abstracts screening and then full test screening guided by our eligibility criteria. And finally, we arrived at 24. Of these 24 articles were spread across 11 low and middle income countries. We had 7 articles coming from Brazil, 4 from India, and Ghana, beloved country, made 3. And that's amazing, and that's the only country qualifying from Ghana, Africa, and that was nice. The rest with very minimal contribution. So with the result, we were able to pull results for the 5-year biochemical failure. That is, after 5 years, patient blood samples were tested for the PSA level, and we want to know were they above 0.2 nanogram per milliliters? I mean, the individual studies, that was what they sought to find. So for the treatment, we have what we call 2DRT, 2 studies with a pool sample of 271, reported the highest prevalence of 34%. 2D is an old technique. You say the traditional form of radiotherapy where treatment is not confined to the tumor. So as you can see, most patients failed compared to the advanced 3D conformal radiotherapy and the brachytherapy. In terms of survival, it is interesting to note that when treatments were combined, so we have brachytherapy, advanced form of external beam radiotherapy, known as a 3-dimensional conformal radiotherapy, we have in almost 100% of the patients surviving at 5 years. For the individual, we have it in about 87%. We ran a meta-analysis for those that received surgery, and we didn't get data for 5 years survival, but then we have for 4-year biochemical failure, and that was around 22%. You know, this is a systematic review. You want to know the differences in studies. So these are the heterogeneities values that were obtained. These were results pulled from the forest plots that were generated, and the heterogeneities were quite high with significant input. In terms of toxicities, I mentioned gastrointestinal, genitourinary, and skin. So with that, we realized that the grade 1 disease or toxicities were more prevalent. In terms of toxicities, grade 1s are mild. And as you can see, grade 2 to 3, the prevalence were quite low. In terms of the grade 1 acute, we are having the skin reactions being the highest, recorded 46%. This is not surprising because in external beam radiotherapy, where you are having radiation incidenting through the normal tissues to the target, the normal tissues is definitely receiving some treatment, and this is still a challenge now in our clinics where patients are having side effects. But on the whole, we could say our findings were favorable. The findings were also comparable with the other high-income countries' results. But the limiting factor is to do an outcome study, you need a long-term follow-up to really make a substantive evidence or information of the findings. So in our primary study, we will be doing a 15-year retrospective study where we can get a good number of information on survival and then death. We realized that in the systematic review, we didn't get information on what patients are saying from their treatment. After treatment, what is bothering you? Are you having challenges with your bowel? Are you having challenges with your urinary or sexual functions? So we want to explore that. At the end, someone will say, and so what? So from these findings, we want to put together and design a nomogram that when someone's father or grandfather gets to the hospital, we can assess the situation and predict that if you're going for this disease with this condition you have in this year's time, you are going to get this outcome or face these challenges. So at the end of it all, then what again? So we hope that this study is going to support localized prostate cancer clinical decision making, because now with the practice of evidence-based medicine, clinicians and patients need to come together to have understanding of their disease. You need to know the challenges associated with the various treatment options that you're going in for. So I'm just grateful to all those contributing to my research journey. This is together with the study included. And thank you.
Thank you very much, Doris. Any questions for Doris? Yes, there's one there.
Hello, Doris. Thank you for a wonderful presentation. My question is that you mentioned that the studies were assessing the levels of PSA below 0.2. And I was wondering, in a clinical setting, our reference ranges in the laboratories, the minimum is actually up to 2.5 nanograms per ml for PSA. So for patients who probably from their AUA symptom score have very low symptom score with PSA less than 2.5 without any, clinical presentation, would assume that they have, they have relatively normal prostate presentation. So why the 0.2 for your 5-year response? Why did those studies consider 0.2 and not what is done in the clinical space? Thank you.
Yes, so as the presentation goes, is outcomes and toxicities post-treatment. So you are reporting on initial PSA level. So after treatment for radiation therapy, we expect that the prostate level should fall below 0.2 nanograms per ml. But in surgery, the recommendation is 0.4. So that is come again. Yes. So you've treated the tumor, and is in the vicinity of the cancer, is in the vicinity of the prostate. So the prostate is contributing to this serum antigen level. So we want to know that really the treatment has been effective. So with that limit, we can be sure. If you put it at that normal, probably there's some cancerous cells that is contributing to that, which we can't tell. So we are providing the most minimum limit that could provide that result. Yeah.
Any other questions for her? Okay, I want to ask you a question. I heard you talk about wanting to do a 15-year retrospective study. In practical terms, what will you do?
Yes, so I'm looking at hospital records, yes. And from 2000 onwards, retrieve all these records and try to get to know the patient that have survived up to this time. So
you said you want to do a 15-year retrospective study. So I assume that you would start, first of all, you start with which cases, and you look back 15 years to find out what. So just walk me through the journey of this 15-year retrospective study and tell me what you'll be looking for at each step.
So when patients are treated, we record, they come for review every time the toxicities are being recorded. In terms of the outcomes, you would be able to know if patient died, it will be recorded. You can use the survivor analysis method to calculate patient survivor for it. So going backwards through records, we could follow patients upwards, is doing a sort of a longitudinal study backwards.
Okay, so when you say 15 years, you are saying 15 years since they were diagnosed? Yes. Okay, so you look back as far back as 15 years, but that means it would include some who are 10 years?
Yes, so to really make a sensitive evidence, 10 years and upwards is, yes, it's meaningful, but less than is always questionable. And now these studies we are having 5 years. Yeah.
Okay, any other questions? I wanted us to go into the details of the study design and the secondary data analysis you'll be doing, but I think I should not do that. So thank you very much, Doris. We appreciate that. Thank you. Clap for her. Yeah. Okay, next we're going to have Dennis Jesse Kunedu. And Dennis will be giving us exploring the correlation between bacterial vaginosis and preterm delivery in the middle belt of Ghana. You have 10 minutes.
Thank you. Thank you, Chair, and good afternoon to you all. My name is Dennis Jesse Kunedu, and my supervisors are Dr. Alex Owusu Ofori and Dr. David Dosu. My topic is on exploring the correlation between bacterial vaginosis and preterm birth in the middle belt of Ghana. So this will be my presentation outline. I'll go through the introduction, and I must say this study is still ongoing. We're yet to attain our sample size and also do further analysis. So I'll give some preliminary results. So by way of introduction, preterm is the second leading cause of neonatal death according to WHO, and 10% of all live births occur through preterm. WHO defines preterm as all birth occurring before 37 weeks of gestation or less than 259 days, counting from the date of the woman's last menstrual period. There are several causes of preterm, and some of them are biological factors, environmental, nutritional factors, and of course, vaginal infection. We'll be looking specifically at bacterial vaginosis here. So for bacterial vaginosis, it's when is the altered state of the vaginal microbiome. So for a normal microbiome, we expect to see higher bacteria in terms of lactobacillus, and they are predominant, about 95%, and there are other minor ones. But when it's altered such that the other minor ones take over, so in a layman's term, you say the good and the bad bacteria. When the bad bacteria take over, then we have a condition called bacterial vaginosis. And these studies have shown to increase the risks of getting preterm birth. So there are several methods for which we diagnose bacterial vaginosis. The gold standard is called the Nugent criteria. And for this, you'd quantitatively evaluate a grand stain smear of the different type of bacteria that you find on the smear. And if you count a lot of lactobacillus species, there's a score that you give it. If you count a lot of the other species, then you give it a higher score. Then you can diagnose the person as having bacterial vaginosis. The other methods, such as the Hayes criteria and the Amsel method. But there's a more precise method using the 16X ribosomal RNA gene to be able to identify all the species, and you can even quantify them. So some of the studies that have shown this association, for instance, Digilio in 2012 concluded that the risk of preterm was higher in patients within a community state type poor in lactobacillus. And so this community state type was a term coined by Ravo Ita in 2012 when he did a study using the 16S ribosomal RNA, and he classified them into 5 community state types. So depending on the dominance of the lactobacillus, this was the classification was given. And community state type 4 was those who had bacterial vaginosis. So Tabi in 2018 also said a bacterial vaginosis related vaginal community state type may be associated with increased risks of early preterm. And Kama in 2021 also said predictive abnormal vaginal microbiota signatures of preterm was detected in as early as the first trimester. So what's the rationale? Why are we carrying out this study? So in Ghana, the studies have shown an increasing trend in preterm birth, and there's a major challenge. So a study in a tertiary institution, hospital, actually saw an increase of from 9.3% to 18% over a decade for preterm. And there have been several studies, as I've mentioned earlier, that have actually established this association between bacterial vaginosis and preterm. But despite this burden of preterm, there have not been any major studies in Ghana to look at the composition and its in relationship with preterm. And to be able to achieve the WHO 2010 goal of reducing mortality due to preterm by 50% in 2030, it's essential that we look at the risk factors of preterm and also their dynamics in different settings as well. And so this study is very important that we look at the population-specific study within our catchment area to be able to improve our knowledge on BV and preterm. So as part of my PhD work, this is my first objective, and that's to look at, to explore the correlation between BV and preterm. And so specifically, we're looking at the prevalence of BV and preterm birth, then look at some risk factors, some associations, and we're also doing some sensitivity and specific analysis on the different methods for diagnosing BV. So the study area was in the Kentapon North and South District. It was a cross-sectional study embedded within an ongoing cohort study of pregnant women. And the pregnant women were aged between 15 to 49 years. They were consented, and a questionnaire was administered on their demographics, their history of vaginal infection symptoms, and their lifestyle. So the sample size for this study is 382 participants. So a trained midwife collected two vaginal swabs when they were at the gestation of 20 plus or minus 2. The swabs went through a laboratory process. We did the Nugent criteria, as I mentioned earlier. Wet mount will look for clue cells, yeast infection, and trichomonads. We did the whiff test. pH was also looked at, and we did a culture for the swab for Candida. So the data was entered into RedCap software, and Stata 14 was used for the data analysis. So by way of some preliminary results that we've been able to generate, so looking at the demographic characteristics, pregnant women aged between 20 to 34 were the highest, about 84.6%. Then most of them were married, 93. By education, realized that those who had no form of education were almost 40%. And occupation, about 77% of them were working. So let's look at this graph. So this, the first graph is on the prevalence of bacterial vaginosis, and this was 17.5%. If you look at preterm, in the study area, the preterm was a bit lower, which was about 5.8. Looking at the risk factor in terms of the demographics, there were no significant association between all of them, except those who were not married, who had the risk of having BV. In terms of the association between BV and preterm birth, when we looked at we did a chi-square test, it wasn't significant. So by way of discussion, the reported prevalence of 17.5 in this study is lower compared to a study that was carried on 8 years ago in the same study area by Kododu et al. This was much lower, almost half. And the study results showed that BV using the Nugent criteria had no association with preterm birth as reported by other studies. This was due to probably the differences in the method and also the geographical location. So by conclusion, bacterial vaginosis infection during the second trimester of pregnancy does not appear to be an independent risk factor for BV. I recommend further research in this area, and as part of my PhD work, I'll be doing some molecular work. So we would have a case study, a case control study, where we would have cases of preterm and term, and we'll do some molecular analysis using the 16S gene. So I thank my supervisors, the director of KHS Research Center, and community members. Thank you very much.
Thank you, Dennis. Any questions for him? Yes. Let's start with the lady, then we go to the gentleman sitting by her.
Thank you for the presentation. So I have 2 questions. So I just want to find out why Kintampo. And then also you made mention that for pre-birth, it is usually less than 37 weeks, but you took the samples at 20 weeks. So I just want to find out why.
All right, thank you for your question. So for the study area, Kintampo seems to be in the middle, the transition between the north and south. So it's very ideal to get in such area. And also, as I mentioned, it's within a bigger study. So we took leverage of the fact that the study is already being carried out, so you'll be able to collect some sample alongside. And the second question was on the preterm. Why is, sorry, come again.
So you considered preterm to be birth below 37 weeks,
yeah.
but the doctor took the sample at 20 weeks. So I just want to find out why.
Yes, so first, most of our study participants that we enrolled, the enrollment starts below 20 weeks. So we decided to target the middle part of the pregnancy gestation. And also, most of the studies that I read around, most times they looked at around the second trimester and its impact on preterm birth. And so that's where the focus was on.
Have you answered her question? She's telling you that you took it at 20 weeks. Why at 20 weeks when you could have taken it in a different age bracket?
All right, so thank you. So as I made mention of, it's all the participants that we enrolled were mainly around 20 weeks. So I took advantage of that.
Could that explain the fact that you had 17.5 instead of the 30.9 which others had? Could that explain?
It's possible.
The next question.
All right, thank you, Professor, and good presentation. I have a two-part question. The first is if you could elaborate on the case control study you would want to carry on later. And my next is, are you considering any possible antibiotic treatment of these women and how it may implicate on your results? Thank you.
Yeah, thank you very much. So the study was, the focus was not to treat the woman, but whatever finding we had, we gave it to the mothers to see the clinician for treatment. And as I said, it was just a cross-sectional, so there was no any follow-up done on that, right? And the first question was to look at, please can you come again? The case control, yeah, the case control. So for the case control, we we've gotten our sample size, we are going to look at 20 preterm cases. So it's 1:3, 20 preterm cases and 60 term cases. And we've collected samples which have been stored in DNA RNA short. So we are going to do a 16S RNA sequencing. And when you do that, you'll be able to look at all the different species in the biome, and you can quantify them. We can do some ecological analysis with that too. Yeah, so that's what we are going to do. Thank you.
Any other questions? Yes, sir.
Thank you. Yeah, so you took your first sample at 20 weeks, and preterm is closer to 37. Why didn't you look at the possibility of collecting another sample in between, maybe by the 30th or what?
Yeah. So I must say we took another sample at 32, but for this study, the focus was not on that. So the focus was mainly on the 20 weeks gestation. But going forward, after the PhD work, if they need to look at other in terms of looking at the transition between probably the 20 weeks and the 30 weeks and see if somebody had bacterial vaginosis probably in the 20 weeks, 30 weeks, did they resolve, and what were the implications for the preterm, for the birth delivery? We'll look at that in the future.
Any other questions? Yes, Thomas.
Mine is a bit of suggestion. I think this is for an award of either master's or PhD. And defense, it will be unacceptable to say that you chose Kintampo because it is part of a study. They had a reason for choosing Kintampo. And advice you get to know. Maybe they may have some demographic characteristics that may predispose the people to whatever they are looking out for. So please get more into the project to understand it. Thank you.
Okay. Any other questions for him? Okay, thank you so much. Oh, there's an hand up. Okay. Yeah.
Thank you very much, and congratulations on your presentation. If I get your topic right, is exploring the association between VV and then preterm delivery. And in your presentation, you mentioned that in literature they have reported association between the two, some not. So I would want to know what makes your work different from what already exists. Thank you.
Yeah, thank you very much. So, as I mentioned, this it has not been carried out in Ghana. This is the first time we are doing such work. And it would be good to know, have a population-specific data on what happens in our locality. Interestingly, the preliminary analysis we've done shows no correlation, but some other studies are showing this. So that's one of the reasons.
So is it possible that you got those results because you actually did it at 20 weeks? Only for most of them?
Yeah, it's possible. And other studies also did it at 20 weeks and they had different results.
So you have other studies to compare with which actually did it at that time. Okay, thank you. Thank you so much, Dennis. Oh, I think there's another question coming from.
Yes,
Prof.
yes. I want him to interpret the conclusion he showed us for us. It's confusing. I don't get it.
Okay, so with the bacterial vaginosis was actually diagnosed in the second trimester of pregnancy, and we are looking specifically at the risk of preterm if somebody has bacterial vaginosis. So if you take preterm cases, and if you look at the preterm, those who had bacterial vaginosis at second trimester, and you take the preterm cases in a whole, it doesn't appear to be independent.
Did you do any significant testing?
Yeah, we did some p-values.
Okay, Dennis, I think you should. Thank you very much, Dennis. Thank you very much. Thank you. Okay, so we'll have the last presentation from Irene Apere-Ejei, and she'll be talking on Group B Streptococcus colonization. And you have 10 minutes to do that. Thank you.
Good afternoon, and thank you for the opportunity. I'm Irene Apere-Ejei, and this work is supervised by Prof. Newton, who also doubles as the chair for this afternoon session, and by Drs. Enyame and then Dr. Kweku Puku-Asante. I'm presenting on Group B Streptococcus colonization, seroprevalence, and serotype-specific IgG antibodies transplacental transfer among pregnant women in Ghana and Zimbabwe. That's quite wordy, right? So I'll try to break it apart a bit. So serotypes looks at the various types or variants that a bacteria or a virus is found. So in terms of Group B Streptococcus, it has been differentiated, or there are 10 different serotypes, which are classified based on Roman numerals 1A to 9. IgG are antibodies that the body produces in response to an infection, such that if there's a later infection, it can fight against it. So transplacental transfer looks at the transfer of these protective antibodies from the pregnant woman across the placenta to the fetus to offer protection or partial immunity to the fetus. This will be the outline of my presentation. Group B, Streptococcus agalacti, or Group B streptococcus, is a gram-positive bacteria that colonizes the gastrointestinal or genitourinary tract of adults. It's part of the normal flora, and its studies suggest that it's prevalent in all regions of the world, although there are variations in its prevalence and the number of studies that are published in different parts of the world. A systematic review suggests that globally about 10 to 35 pregnant women are colonized with Group B streptococcus. Some who are colonized with Group B streptococcus go to give birth to healthy infants. However, about 50% of those who are colonized transfer the bacteria pass the bacteria to their infants. Group B streptococcus is a known risk factor for stillbirths and then preterm births. And it's also associated with sepsis, pneumonia, and then meningitis among infants, which is quite worrying, because if we look at the Sustainable Development Goal number 3, which looks at reducing infant and child deaths to 12 per 1,000 live births, we are lagging behind when it comes to this. It manifests as early onset of disease if it occurs within the first week of life, and as late onset of disease if it occurs after the first week of life, up to 3 months after birth. Some developed countries like the US have adapted screening of pregnant women when they are 35 to 37 weeks gestation, and then they offer intrapartum antibiotic prophylaxis to the pregnant women. In the UK, they have adopted a strategy whereby pregnant women who have had a previous infant with invasive disease or who are currently colonized are also given antibiotics prophylaxis. Over the years, this has been shown to decrease the number of early onset of disease, but has had no effect on late onset of disease. It also has no effect on preterm births and stillbirths. Low and middle income countries, which carry the highest burden of GBS, are unable to implement intrapartum antibiotics prophylaxis due to logistical challenges in routinely screening for this. High income countries where this is practiced, they have compliance, they have cost, and excessive use of antibiotics as challenges to beckon with. A maternal GBS vaccine, therefore, looks like a promising alternative to the intrapartum antibiotics prophylaxis because it could offer protection against both early onset and late onset of disease, and could also potentially reduce the stillbirths and preterm deliveries related to Group B streptococcus. Currently, there are no licensed vaccines for Group B streptococcus. However, several vaccines are under development. Some have been developed and they are in various clinical trials, including phase 3 clinical trials with promising results. The prevailing serotypes would indicate which type of vaccine will work best in which locality. Also, in the African region, it has been shown that serotypes 1 to 5 accounts for about 92% of the serotypes identified. The objectives of the study is to determine the prevalence and serotype distribution of Group B streptococcus among pregnant women in Ghana and Zimbabwe, and also to determine the transplacental transfer of serotype-specific IgG antibodies. The study was a multi-center, population-based cohort study carried out at the Kintampo Health Research Center in Ghana and the Center for Sexual Health and HIV Research in Zimbabwe. Pregnant women were recruited from study communities and they were followed up till childbirth, and if they had a live birth, the infants were followed up till they were a year old. Our eligibility criteria included pregnant women whose gestational ages were 13 to 27 weeks and who gave consent to be part of the study and resided in the study area. Residing in the study area was necessary because of the biological samples we were taking and then the need for the 1-year follow-up. So for the participants who were recruited into the study, they were followed up monthly, and if they had any morbidity that was suspected to be a urinary tract infection, urine samples were taken to culture GBS, and also upon the recommendation of the clinicians attending to them. There were instances where a high vaginal swab was requested for. At 36 weeks or prior to delivery, rectovaginal swabs were taken from all the pregnant women, and then 5 ml venous blood was also taken from the women. At delivery, cord blood samples were taken from the infants. And during the 1-year follow-up of the infants, if they were sick and it was suspected to be sepsis, blood samples were taken for culture of GBS. The rectovaginal swabs were transported to the laboratories in KHRC and in Zimbabwe, and GBS was isolated. The isolates were stored and transported for serotyping. The serotyping was performed using the latest agglutination methods and then quantitatively using the multiplex Luminex platform. Ethical approvals were sought from these institutions. A total of 1,238 pregnant women were recruited from both countries. By the time of delivery for Ghana, we still followed up about 91% of the pregnant women who were recruited. But for Zimbabwe, by delivery, the follow-up rate was 58%. The baseline socio-demographic characteristics of the two countries were similar. That of age were similar. Education was exclusive in Zimbabwe, and cohabitation was similar for both Ghana and then Zimbabwe. We also realized that there was a high unemployment rate in Zimbabwe compared to Ghana. Most of our participants carried their pregnancies to term. But what is worrying here is the neonatal death rate. We realize it's about 5% for Ghana and then 3% for Zimbabwe. If we are looking at it in terms of deaths per 1,000 live births, that's about 50 per 1,000 live births for Ghana. And that's quite worrying looking at the Sustainable Development Goal 3. Low birth weights among the Ghanaian population was about 9% and 11% for Zimbabwe. Overall, the prevalence of group B streptococcus colonization among the pregnant women was 15.4%. It was 15.6% for Ghana and then 15.2% for Zimbabwe. 8 serotypes were isolated from both countries. Serotype 1A, 3, and 5 were the prevalent serotypes identified, accounting for about 85% of the serotypes. Looking at the geometric mean concentrations of transplacental ratio, we realized that for Ghana, most of the values were close to 1, meaning there was optimal transfer of antibodies from the mother across the placenta to the infants, and these were much lower for Zimbabwe. We restricted this to maternal and cord blood samples that were collected within 2 days, because although the samples were taken at 36 weeks, after 36 weeks gestation or prior to delivery, we have pregnant women who give birth at 40 weeks. So if we took a sample at 36 weeks and later she gave birth at 40 weeks and we are taking the cord blood sample, looking at the transplacental ratio, we might find differences. So this was restricted to 2 days of the samples being collected apart. So overall, the prevalence of maternal GBS colonization was about 15%. The results are comparable with other prevailing serotypes globally and then in Africa. A trivalent vaccine that targets 3 serotypes, that's serotype 3, 5, and 1A, will cover about 84% of the serotypes identified in the study area. If it's a hexavalent vaccine, which covers serotype 1 to 5, it could provide protection to almost all the GBS cases identified in our study population. However, in the last 10 years, we realized there are very few publications in this regard. And if we are positioning ourselves for a vaccine, it will be important to know what the burden of the disease is, or what the burden of the infection is in our locality. So there is the need for more studies to quantify the burden among pregnant women. And we have also learned from the COVID-19 pandemic about vaccine hesitancy and vaccine resistance. So there's the need to conduct studies on perceptions of vaccines for pregnant women to help us tailor messages and interventions that will increase vaccine uptake should a vaccine be finally made available to us. I'm grateful to the huge team that made this happen. Thank you for your attention.
Thank you, Irene. Any questions for Irene? Okay, I'll set the ball rolling if you want to ask questions. Let's go to your inclusion and exclusion criteria. Let's go to that slide. Okay. Okay. Do you think your first exclusion criteria is a valid exclusion criteria?
Yes, sir. I think the first exclusion criteria is valid because spontaneous abortions occur prior to 13 weeks. So we didn't want to include pregnant women who might have spontaneous abortion and would associate this with GBS. And also for the 27 weeks, we know for preterm deliveries, usually they occur after 27 weeks. So that's why we looked at the inclusion criteria of 13 to 27 weeks.
What do you understand by the term inclusion criteria?
Okay. So inclusion criteria looks at the things that you look out in order to qualify someone to be part of a study. So for pregnancies, for some as early as 6 weeks, they are able to tell you that they are pregnant.
So the first one is not part of it because you say your inclusion criteria are those between 13 to 27. So the first exclusion criteria does not even fall within that group. So you don't even bring it there because it's not part. You only say that, for instance, those who have moved out, those who don't intend to study, that's fine. But the ones you've put there shows that for you to even be considered, you must fall within 13 to 27. So writing the other one, it's a lot of students make that mistake, but it was never part to start with. The second one, you said you had 58.2% loss to follow up in Zimbabwe. And then you had 58.2 were followed up. And 91 in the Ghana one. Now, if you have such a big loss to follow up in one of your comparator groups, what is the risk you have in terms of interpretation of your data?
Okay. So I would first explain why we had this huge loss to follow up for Zimbabwe. There was political and economic instability at the time, halfway through the project. So we had healthcare workers in Zimbabwe going on strike at 3 time points during the project. That in 2019, they went on strike from February to March, from November to December. And then in 2020, they went on strike from July to September. And this also affected healthcare practice there because a lot of health facilities.
The interpretation, could the results have been different?
So that is why we see a difference in the results between Ghana and Zimbabwe. When we even look at the transplacental transfer, we realize that it was optimal in Ghana because for Ghana we had more samples compared to Zimbabwe. For Zimbabwe, we had only 8 samples for the transplacental ratio, which were taken 2 days apart.
So when it comes to interpretation of your work, would you state this as a limitation? Would you state it? Okay, my next question. Have you got any questions now? Okay. I was going to ask more, but someone wants to ask, so please let him ask.
Okay, thank you. That was a wonderful presentation. Well done. I want to know how you address mixing data due to the follow-up.
So we would analyze only complete data. So if it's missing, we don't have that variable.
Won't that affect your power?
So if not, we will have, okay, so we would, let me. Yeah.
Won't that affect the power of the study?
So for Ghana, we have very low missing data. So we'll analyze it as it is. But for Zimbabwe, where there's going to be a huge amount of data missing, we will consider multiple imputations to make up for the lost data that we have.
Any questions for Irene? Since there are no more, let me continue. Was the study, what the sample of, don't worry, I have time, we have time. You see, we have finished too early, so let's get to the classroom. The study, the sample size, when you were showing the flow chart, you showed the total number of Ghana and Zimbabwe together. Therefore, that gives us the impression that the study was powered with two countries in mind. Is that clear? Very good. So if the study was powered with two countries in mind, is there any point in interpreting each of the countries individually when the sample size was never intended to analyze them separately?
So this formed part of a bigger study where other infections were being looked at, and that all went into the sample size calculation. If we are looking at the prevalence and the serotypes, we have more than enough power to do this interpretation. The limitation will come with the other infections that we're looking at risk factors. So for this, it's power to do that.
That's an excellent response. I didn't expect you to be able to answer it. No. Okay. There's a question out there.
Thank you for your presentation. So please, my question is, why not Togo, Burkina Faso, or Ivory Coast, but Zimbabwe? Thank you.
So this was in response to a call from the European Commission, and it was looking at countries where we have limited data on GBS colonization, but they were also looking out for an African and Southern African collaboration. So that's how come we collaborated with Zimbabwe to carry this out.
Any other question for her? Your last result slide, I want us to look at it. Your last result slide. No, you're going forward, go back. No, the next one. Just go on, continue. Very good. In terms of your transplacental ratio for Ghana and then for Zimbabwe, what do you find interesting about the confidence intervals? Just look at it and tell me.
Yeah. The confidence intervals are wide, especially for Zimbabwe, and this is due to the small sample size. As I mentioned initially, we had only 8 paired maternal and cord blood samples for Zimbabwe. So this accounted for the wide confidence interval.
It's not often that I'm rendered speechless. Okay, any other questions for any of the other people who presented? Okay, thank you very much. I would hand over to the chairman of the planning committee because we finished. So the closing ceremony.
Thank you very much. I'll give a closing remark, so I'm not going to give any lengthy remarks. Just to let you know that we are tallying the marks for the awards. So please just sit down and wait patiently. But in the meantime, the faculty, the schools have documentaries about their schools and faculties, which we are going to show you. So please sit down and enjoy as we tally the marks. Thank you very much.
Good afternoon to you all. We're going to start with the closing ceremony. And I would like to let you know that we would have 6 awards before we close this program. The first award will be the overall best oral presenter. And that award's name is the Professor Richard Odame Phillips Award for overall best oral presenter. And for that award, the person is going to receive sponsorship of $1,500 to attend an international conference. That is air tickets, accommodation per diem. Or if you are not at the point of presenting at a conference and you would need support for your research work, you would use the funds for your research needs. Then for second best oral presenter, that is named Professor Alexander Debres Award for second best oral presenter. And that is a brand new laptop worth 10,000 cedis to support students' research activities. I think you should applaud these awards. And for the third best oral presenter, that is the Provost's own award, Professor Christian Ajari's award for third best oral presenter, a brand new tablet worth 5,000 Ghana cedis to support students' research work activities. Then those who worked on posters, you will not be left out. We have the overall best poster presenter. That is the Professor Peter Donko's award for overall best poster presenter, an amount of 3,000 Ghana cedis to support research activities, including consumables, reagents, or field activities. Then we have the Professor Fred Sappho's award for second best poster presenter, an amount of 2,000 Ghana cedis to support research activities, including consumables, reagents, or fieldwork. Then finally, Reverend Professor Charles Anson's award for third best poster presenter, an amount of 1,000 Ghana cedis to support research activities, including consumable reagents or field activities. Who would this be? Who would fall in one of these 6? And I'm happy this is something to motivate all postgraduate students for upcoming years to know that when you work hard, you can receive something for your hard work. Are you energized for next year? Even if you are not receiving anything for this year, there are so many lessons to learn for the next year. So as we wait for the marks to be compiled, we'll just call if students have any suggestions for next conference, any expectations, anything that could be done to make the conference richer next year. Please, you are welcome to say that. Anyone has anything to say? Or because of the awards, you don't want to say anything that... Did I see a hand? So you were satisfied with everything? Totally satisfied? Okay, there's a hand up there, please.
Good afternoon. First of all, I would like to acknowledge that the organizers did very, very well. They did an amazing job. I only have a little comment concerning pairing the poster presentations with the snack break. I think it wasn't well coordinated, and some people may have gone to have the snacks whilst the poster presentation was in session and the other way around. So they may have not had an opportunity to actually interact with people regarding their work. So that's my only concern. Thank you.
Okay, thank you very much. Conference organizers, the suggestion here is to have different times for the snack and poster sessions so that they can interact well. Yes, please.
Thank you very much, Madam. my concern has to do with the parallel presentation. Those that were held on the first floor had the least of attendance. And I think that's also is something that needs to be looked at. Thank you very much.
Okay, thank you. Very well noted. We are very grateful for these honest suggestions from you. Please, is that all? And the announcement is that all those who didn't get food, food is available upstairs. You can go with your chit and then have your food. Hope that makes you happy. Okay, any other, even something you were happy about, you can still let the organizers know. Whether you appreciated something, there's something to comment about. Okay, I'm sure because of the awards. Okay, Prof. Newton had something to say.
I would like to commend the organizers for the way they handled this whole program. I remember I went to the poster presentation, and the posters were of high quality, and there were students standing by the posters ready to engage those who had come around. And I think it's good, because you see, if you don't build your confidence with these, starting from here, when you get on the international stage, you'll be so intimidated that you don't even know what to say and what to do. So once you present, and I mean, you learn by doing. So once you present and you get the chance to present posters, next time you are invited to travel somewhere because Bill Gates wants to see your face, when you go there, you make a beautiful presentation. So you've done very well, the organizers, and the students have also done very well. Their confidence level was very high, which is commendable. Well done.
Thank you very much. Now we are ready for the video, so you can have a good watch at what is happening in the various departments and schools. Thank you.
I always tell my students that diseases do not require passports to travel. People travel around the world. So
if people are carrying diseases, even on the plane, you can spread some of these diseases. And also, you can go to certain places and just pick a disease, and it's just a flight away from your country. And when you come back, it can be spread. So these are, and it's amazing, these are the issues which confront us nowadays, and many, many people are now choosing a career in public health, so they'll be better placed to address some of these issues when they arise. And that's where the School of Public Health has a vision to train a high caliber of public health practitioners to meet these challenges.
Dental education has two parts, where you have the first 3 years where our student will have to do the human biology. So it means that during that first 3 years, the medical students and their dental school, counterpart will have to be in the same class until the level of junior clerkship. Then after, then the candidate will have to come to the dental school proper, where we have the BDS program. So the terminal degree that every candidate will have to acquire before he or she can practice as a dentist in Ghana is what is known as the BDS program. That is the Bachelor of Dental Surgery. So the Bachelor of Dental Surgery is the certificate that you need to be able to practice as a dentist in Ghana. And the whole program duration is 3 years. Most of the time, the first 3 years is done on campus. Then after that, you come to the Konfanochi Teaching Hospital to come and do your clinicals for you to acquire the Bachelor of Dental Surgery. And basically, dentistry is hands-on. So this course involves a lot of practical work. Okay, so you come, we teach you how to take your own dental x-rays. We teach you how to fabricate your own artificial teeth, dentures, teach you how to do fillings and then other advanced prosthetics in dentistry. You are also involved in the x-ray development, oral pathology, oral medicine, and then we have the oral and maxillofacial surgery. Then we have the other department called the orthodontist and child health. So it's basically a hands-on your program, and the clinical stage is quite intensive. The good thing about dentistry in terms of the training, which is different from other subjects, is that, because it's a hands-on, the student will have to acquire certain clinical competencies before they can pass and become dentists. So in the course of the training, we teach you in the phantom head. Phantom head is like a simulation center where we train our students on most of the procedures. Okay, so you need to pass the phantom head room. Okay, that is, as I said, it's a simulation before you can now move to the clinical stage. Okay, or you go to the clinics and then you are encouraged to attend to patients under the supervision of your supervisor, that is the consultants and then the lecturers. So before you graduate, you should be able to do certain procedures. You should know how to comfortably examine a patient, dental patient, extraoral examination, the systemic examination, and you should be able to do basic procedures including dental extraction, fillings, crowns, and bridges, root canals. So we give you requirements, and you need to fulfill all the requirements before we can say that you are qualified to be a dentist.
This is a KNUST School of Medicine and Dentistry documentary.
Over a long period of time, you're looking for answers in trying to solve the problems that bedevil our people. In this case, we have been researching in the last 20 years in a very important disease that causes fever in Ghana. And this disease, as you are coming to witness today, is typhoid fever. Today, the works that we have done in describing the burden of typhoid fever is culminating in the commissioning of this wonderful state-of-the-art facility that will help us to be able to start a vaccine trial as a solution to the management of typhoid fever. So the essence of this morning's program is to ensure that we outdoor this vaccination program that will see the end of typhoid fever as far as Ghana is concerned.
We've worked in this Asante Action Committee for a long time. The vaccine trial is being held in the Asante Action North and Central communities. We've worked there for a long time, over 10 years, looking at the burden of typhoid fever, looking at the microorganism that causes typhoid fever, looking at its antimicrobial character, looking at its genome. There's a lot we've done over the past years. So today we are continuing with the whole typhoid study with this vaccine trial. We are enrolling 23,000 participants.
See, we talk about phase 4 trial. It means the product has already been granted market authorization. The regulatory authorities have agreed, including our own FDA, have agreed that the product is safe and effective, for use. So now we want to expose it to a large number of people, and consolidate the safety data. So the question of safety, there's no question of efficacy, and safety. And the purpose of this, in most of the times when you are looking for data in Africa, all right, it's very, very difficult. So the purpose of this phase 4, here, is to get that data, to consolidate the safety of the product. And then after that, when we are very much assured, of that, then just like my senior said, it can be rolled on the EPI. We have adequate, data, to suggest that this product can be used. But it's not the first, it's not the first time that this is actually being used. It's actually being done elsewhere. But on Africa, we don't have, that much information. So I think this is really wonderful opportunity, for us to be involved in this trial. So basically, that's about it. The safety is assured. There's not much about the safety, but we just want to have the data. We want a larger number of people to be. People have been exposed from phase trial. Approval have been given from phase 1 trial, phase 2 trial, and phase 3. And all the regulatory authorities, we've looked at the data, the dossier, and they've granted authorization that it can be used, all right, for preventing infections, in typhoid fever. So we are doing what is called the phase 4, which is basically on pharmacovigilance, trying to follow up, more on it, and consolidate the safety. And if there is any hidden, safety information, this is also the time that we'll be able to pick it.
My research topic was on factors influencing malnutrition in children from 6 months to 2 years of age in the Asante Akim North District. I took this research because I realized that in Ghana, according to the United Nations Children's Fund, close to 1 in every 5 children under 5 years is stunted, while 1 in every 10 children under 5 is underweight. Almost 2 in 3 children between the ages of 6 months to 2 years are not fed food that supports their rapidly growing bodies. So in turn, these children are put to serious risks such as poor brain development, weak learning, low immunity, increase infections, and in many cases, these children die. So I took this research to be able to determine the knowledge that these primary caregivers of the children had on childhood nutrition. I also wanted to find out the feeding practices that these primary caregivers adopt in feeding their children. Also, I wanted to find out the influence of the socio-economic status of these primary caregivers on the nutrition of their children. Lastly, I wanted to find out the strategies that these primary caregivers think can be adopted to help reduce or curb malnutrition amongst their children. In my research, I found out that the knowledge of these primary caregivers was adequate, and most of them attained their knowledge from the antenatal clinics, which I think is a very laudable effort on the part of the health workers in the district, since they are doing a very good job. Also, I found out that most of the children that were malnourished happened to belong to primary caregivers who had low level of education or had unskilled jobs. Also, these primary caregivers happen to have partners or husbands who were not earning enough at the end of the month, at most about 30 to 50 Ghana cedis a month, which was not good enough to support these children. Also, I found out that most of these mothers were practicing the needed or the recommended feeding practices as recommended by the WHO, which was exclusive breastfeeding for 6 months and then complementary feeding from 6 months to 2 years of age. I also found out that majority of these mothers thought that giving children balanced diet and then practicing these good feeding practices as recommended by the WHO can help reduce the malnutrition in the district. To conclude, Owen Arthur, a former Prime Minister of Barbados, once said, "He who has health has hope, and he who has hope has everything." In this regard, I recommend that these primary caregivers and their partners in the said district are encouraged to take advantage of the many educational opportunities that they have in the district, the many educational facilities in the district, to better themselves, so as to help them achieve or attain good works in the society, so as to help take better care of these children, since they are the future of the nation.
Ciprofloxacin, which is very important in treating our enteric sepsis and bacteremia. 63% of Salmonella was resistant, and to ampicillin, 59%. Antimicrobial usage has become very common lately in Ghana, across the world, I would say. People are misusing it for unusual purposes. It has also been used many times in the agro industries, in animal rearing particularly, which enhances the development of antimicrobial resistance. These resistance, when found in humans, will reduce our chances of treating infections caused by bacteria. So it is necessary to monitor the development, the resistance, and the spread of antimicrobial resistant bacteria from our agro industry, which feeds us, so that when there is a resistance in our human population, we may be able to trace the source and then know which antibiotics would be able to treat these organisms. So sample chicken meat sold in Kumasi, both imported and exported, to see how much resistant bacteria strains are inhibiting or inhabiting these or colonizing these meat. This study looked at Salmonella and very resistant E. coli and Klebsiella. The scientific term, extended spectrum beta-lactam is producing E. coli and Klebsiella, or ESBL. And it was found that in Salmonella, there was high resistance to tetracycline, 100% everything, for ciprofloxacin, which is very important in treating our enteric sepsis and bacteremia. 63% of Salmonella was resistant, and to ampicillin, 59%. or more than half. So if infection due to salmonella originating from the poultry industry, it therefore means that treatment may be very challenging, especially when we don't know the antimicrobial resistant pattern of the isolate that is involved. And in the E. coli and the Klebsiella, up to 36% of all samples collected here were ESBA produced were extended spectrum beta-lactamate. This is up from 20% 2 years ago to 36% is huge, all right? And it was found that in the local poultry, it was 44%, and 2 years ago, that was 21%. In the imported ones, 2 years ago, it was 11%. Now it is 31%. So gradually, resistance is growing, becoming a problem. We need to solve this before it is out of hand.
Na me buy me best ram sister mo na awon kam no mo de me coin. Mo de me coin next for no. Omo kro me. Omo nsa na me ho jeje me so o ma me. Ya wo ma ka me wo bi ma ba be chin kula ma. It say na ni je keke.
My research topic was on maternal satisfaction with the quality of labor and delivery services in the Ladadekutupon district in the Greater Accra region. Realized that what a patient may perceive as quality may not necessarily be quality. So my research was to assess factors that affected the level of satisfaction in mothers who had delivered in the last 5 years in public health facilities in the Ladadekutupon district. So I interviewed 223 mothers who had delivered in the last 5 years. And I used the last 5 years because I didn't want them to forget their labor and delivery experiences. And my study was a cross-sectional study. So I listed 19 variables of satisfaction using the Donat-Badian quality assessments, which was divided into the structure, the process, and then the outcome of services. So I asked questions based on the structure, the process, and then the outcome of the services. So from these 19 variables, a factor analysis was done, and then I got my 4 factors which was affected during the labor and delivery services. And I realized that from my study, 74% of the women were dissatisfied with the services provided, especially with the accessibility to the toilet and shower facility, and also with the ambulance services. Most of the women were complaining that where the shower and toilet facilities were far away from the labor ward, and also most complaining that when it was time for them to deliver and labor sets in at home, they don't have the ambulance services to bring them to the hospital. And other studies I read on established that age, education were some of the factors that affected satisfaction. But for my study, I realized that the delivery attendants, the mode of delivery, and then the duration of stay at the hospital were factors that significantly affected the level of satisfaction. And from these variables, I realized that the women who delivered via cesarean section were more satisfied than those who delivered via spontaneous vaginal delivery. On the other hand, I realized that those who stayed shorter at the hospital were less satisfied than those who stayed longer at the hospital. The reasons could be as a result of the fact that those who stayed longer at the hospital were attended to more often, whereas those who were discharged early went home with complications unattended. So from my conclusions, I realized that the level of satisfaction was suboptimal in the Ladekutupon district. And I recommend that at the national level, they should collaborate with other bodies like UNICEF so that they will adopt the WHO framework of quality of care, which states that care should be efficient, it should be effective, it should be safe, it should be equitable, and most importantly, people-centered. I will also recommend to the districts, the regional and district health services, that they should have regular site visits to the hospital so that they will assess the level of quality in those hospitals.
So this is the prosthodontic dental laboratory. Basically what we do here is dentures, either full dentures or partial dentures for patients. So we receive the impressions from the clinics. Then we pour our impression, get our models, we cast them, get our models, we trim them perfectly. Then we set up the teeth. Afterward, we process the cases, we process our dentures, trim them nicely. So on this table we have some of the impressions from the dental clinic, which we cast and get models of this shape. From this model, you could see the patient has lost about 2 teeth. So this is the part we are to replace. So replace this teeth, this missing teeth. So after getting this, we trim it perfectly to shape. Then we use this wax and teeth to set up. So as I said, this is the missing part. The dental part is the missing portion the patient has lost. That's the teeth, which we are to be replaced. So you use your wax and the set of teeth. You trim it perfectly, then we do the setup. Afterward, you process, you trim. So this is the polishing machine. So I'm polishing the final work. That's the denture before it's sent to the clinic for delivery. Then you send it back to the clinic for final delivery.
The School of Veterinary Medicine of KNUST was actually born out of a need to train veterinarians locally. Veterinary education had been on since 1920 with the training of technicians in Pont Tamale. And other people who want doctor of veterinary medicine has to travel outside the country, outside these shores, to Nigeria, Kenya, South Africa, Cuba, Russia, Ukraine, and some to Cuba to get trained and to come back and practice in Ghana. These are through various scholarships and all that. But in 2009, the Veterinary Council of Ghana see the need to produce veterinarians in Ghana. No doubt, the veterinary the number of veterinary doctors in Ghana was grossly inadequate. Where we need over 10,000, we have less than 150. And that tells us, that's going to tell more on the quality of meat, quality of veterinary services, even pet services that we have in the country. The Veterinary Council of Ghana approached two universities, University of Ghana, Legon, and also University, KNUST, Kwame Nkrumah, University of Science and Technology. But I must quickly say, they specifically asked KNUST that their aim of veterinary school is to produce one health specialist, specialists who are not just veterinarians, but will help in pandemics control in future. And for that reason, KNUST in their wisdom.
Please, let's applaud all the deans and all the researchers who have spoken and told us about what they are doing in their various schools and departments. So we have been joined by great professors of the land, and we would like to acknowledge them before we zoom into giving the awards. We were joined by former Pro VC, Reverend Professor Charles Ansah. Please, let's acknowledge him. Also, we have our keynote speaker for this postgraduate conference, who was in the person of Professor Richard Odame Phillips, Director of the Kumasi Center for Collaborative Research. We also have the Dean of Medicine, School of Medical Sciences, Professor Entrikusi. Please, let's acknowledge him. We also have Professor Asarin Kansa of the School of Pharmacy and Pharmaceutical Sciences. We acknowledge your presence. We already acknowledged Professor Eduse in the morning. We are grateful for your presence. And so now, what's the moment we have all been waiting for? I'll call Dr. Linda Debra to help me here as we mention those who deserve the awards. Okay, so we will start with the poster presentation winners. The third best poster presenter. The prize is known as the Reverend Professor Charles Ansah's Award for third best poster. So we will graciously invite Reverend Professor Charles Ansah to present this award, an amount of 1,000 Ghana cedi. And the one to pick this award is Prince George Jr. Aqua. Please, Prince George. Prince George. Oh, this is how rapture will take place. Is Prince George here? Any close friend or supervisor around to pick up this award on his behalf? Oh, yes. And this amount is to support research activities, including consumables, reagents, or field activities. The second best award for best poster is Professor Fred Safo's award. And since he's not here, we would like to call on Professor Asarin Kansa to do us this honors. It's an amount of 2,000 Ghana cedi to support research activities, including consumables, reagents, or field activities. This goes to Mr. Sylvester Newton. Please, let's welcome Mr. Sylvester Newton, placing second for poster awards. Mr. Sylvester Newton, he's also been raptured. Please, any supervisor, close friend, anyone who feels he should do this for. Okay. So shall we move on? Okay, someone is coming. Oh, let's applaud Prof. Newton. Please join him since you are already here. Please join him. Please join to take the picture. Yes, thank you very much for standing in for him. Congratulations to Mr. Sylvester Newton. We'll go on to the best poster presenter, and this is a 3,000 Ghana Cedi award to support research activities as well, including consumables, reagents, and field activities. We would call on that's Prof. Peter Donko's award, and so we will call Professor Ntrikusi to do this for us. Please, let's applaud him. And the one who is receiving this is Mr. Ejay Bay Nicholas. Please, a round of applause. Mr. Nicholas Ejay, congratulations on receiving the Professor Peter Donko's award for overall best poster presenter. Thank you very much, Professor Ntrikusi. Now we go on to the oral presentations. The third oral best presenters award is Professor Christian Ajari's award for third best oral presenter. It's a brand new laptop worth 5,000 cedis to support. It's a brand new tablet worth 5,000 cedis to support students' research activities. Maybe next year's one is going to be a laptop. So, shall we welcome the provost, Professor Christian Ajari, to give this award? And this goes to Millicent Sewama for Ojiri. Millicent Sewama for Ojiri. Please, a round of applause. She receives Provost's Award for third best poster presentation. A round of applause. Congratulations, Millicent. Now, the second best goes, it's the Professor Alexander Debre's Award for second best oral presenter, a brand new laptop worth 10,000 Ghana cedis to support students' research activities. And this goes to Menazi Differi. Menazi. The Conference Chairs Award. Congratulations. Congratulations. We know the laptop will be very useful. And the overall best, what we are all waiting for, that is called the Professor Richard Odame Phillips Award for overall best oral presenter. And this presenter would briefly tell us what you are working on and what is accounting for this award. And this is a sponsorship of $1,500 to attend an international conference, air tickets, accommodation or per diem, or for any aspect of your research you want to be sponsored for. So you choose either or. And this award, shall we have Professor Odame Phillips present this prestigious award? And with a resounding applause, let's welcome Abena Owusua Ado. Abena Owusua Ado. Abena Owusua Ado. A round of applause. A round of applause. And it's so beautiful. She is double, receiving awards in doubles. Please, a round of applause. She receives the Professor Richard Odame Phillips Award, and that is the best, a sponsorship of $1,500 to attend an international conference. Please, a round of applause. Congratulations. Congratulations, Abena Owusua Ado. Congratulations. And if you could see, all oral presenters were female. Please, a round of applause. We will give her the opportunity to speak about what she worked on. Congratulations.
I really don't know what to say. I didn't expect this, especially because we are double now. And working has been extra difficult. Forgive my emotions, but I'm actually shocked. I don't know what to say, but I'd like to say a big thank you to God for this opportunity. My bosses are here. It's been a long journey. I'm sure Prof. Cancer can attest to this. And my landlord, the provost, he's not even aware. He just met me and realized I was pregnant. He was like, Abna, you are pregnant again. I said, yes. So, Prof, this is what the pregnancy is doing. I'm sure you want more of such. Prof. Ansa, from the department, Dr. Idris here, my main supervisor, Prof. Ayensu Sobek, Dr. Abna Kakari, Dr. Zanu. The support has been overwhelming. Even Prof. Joshua Boateng of Greenwich University. And I'm grateful to God for this opportunity that even in this state, it is not a limitation. And that I'm sure a number of us will be encouraged to be able to also do more, even no matter the situation we find ourselves in. I want to thank even my other colleagues. I started this journey, a PhD with a number of them. Most of them are outside. We are still in contact. And I think I have benefited a lot also from their knowledge. So when it comes to presentations, then I try to talk to them so that we share knowledge on how to go about their presentations. And I think it has actually really, really helped me. My work is on the effects, what I presented on was just a part of my work, but it's on the effect of the storage time on the levels of phthalates in extemporaneous preparations. What we did with the work was mainly to look at phthalates. It's technical, but it is not really technical. Anything can be explained. And if I say that if knowledge cannot be explained to the end user, it is useless. So with our various plastics that we have many additives that help to enhance their properties. So we see that some of them have different shapes, different colors. And amongst the additives that are added to the plastics, the significant amongst them is a compound called the phthalates. The phthalates belong to the plasticizers. What these plasticizers do is that they enhance the flexibility and the durability of plastics. So if these compounds are added to the plastics, it makes them flexible and durable, and that's what we also want. However, there are many toxicity concerns with these phthalates. They range from very low toxicity, what we say milder conditions like the allergic reactions, to more serious conditions like the reproductive and endocrine disorders. So, in Ghana, the regulation of extemporaneous preparation focuses mainly on the active ingredients and the labels, with little or no attention to the effect of the packaging on the extemporaneous preparation. A typical case of don't mind the body, mind the engine. So if the engine is good, probably we can move. However, there's a big problem here. What if the body is in a dilapidated state such that it cannot actually even move? So that's the toxicity that we are talking about. So the research was supposed to find out what are the levels of these phthalates that we are recording. And the reason we said extemporaneous preparations were chosen. Extemporaneous preparations, normally we see them MMT, mixed magnesium trisilicate, mixed Senaco, mixed potassium citrate, and the likes. If you've gone to the pharmacy to buy, almost every time you see it in a plastic bottle. So that was the major concern. And as a mother and a wife, I was saying to myself, every day I come back home and everything I buy from the market is packaged somewhat in a plastic container. So if pharmaceuticals are also not spared, why don't I look into what these phthalates are doing? So the idea was to find the levels. And from the research that was done, we realized that as time increases, the levels of these phthalates increase. The control was the fact that we prepare the same extemporaneous preparations, store some in plastic bottles and the others in glass bottles, and monitored over 2 years actually. So upon the analysis after the various time points, we realized that the levels of the phthalates keep increasing in the ones that were stored in the plastic bottles. However, the levels were below detectable limits in the glass containers, showing clearly that there was something coming from the bottles into the extemporaneous preparation. And the other part too was the fact that it wasn't just steady. The levels were increasing. That means that more time you have it on the shelf, the more phthalates that you are introducing into your body. And the good or bad thing about the phthalates is the fact that you are not just taking it from, we use plastics a lot, so you are not even just taking it from the extemporaneous preparation. You are taking it from water, you are taking it from other places. So the cumulative effect, probably in some years to come, we will not be able to measure. So that is the idea of the research. So the whole point was to try and see if we could have alternative sources of packaging for these extemporaneous preparations, and not just extemporaneous preparations, generally medicines in general. The idea of somebody say that, but we can't eliminate plastics altogether. But the point is, we could also look at how we can reduce the levels of phthalates that we have been exposed to. And that would mean that if we can, why don't we go in for the glass packaging? There are even types of the plastics, and all of them have different levels of the phthalates that are in them. However, in Ghana, we always look at the cost. And the more we look at the cost, then that means we would rather fall for these phthalates. And if you would want to buy, the other recommendation was to look for freshly prepared products that are stored in these extemporaneous preparations, in these plastic bottles. That means the closer it is to the manufacturing date, the safer it is for the person. So that was what my research is on. Thank you very much.
Congratulations again, Ms. Abna Owusua Edu. Thank you very much. Please, let's applaud her. It's been an exciting time, and so we would like to hear from Professor Christian Ajari. He's given us the closing remarks for this postgraduate conference. Please, a round of applause for Provost.
Thank you, Dr. Princess Echampo. I think we are all happy. For me, I'm double happy because my former student, my colleague, and maybe now my tenant have received the best oral presenter. Abena, congratulations. I think the past 2 days have been exciting. We've been able to present what we've been working on. We've been able to network with each other, and including senior members, not necessarily in your department or your working group. And we've learned a lot. But the key thing is, after getting to know each other, how are we going to make use of this network and then the possible collaboration that we may have. When Abna was responding, he said they started the PhD together, others are outside, but still they've been working together, even on the presentation that she had. So, as I indicated, and then the planning committee chair, Professor Debra, indicated in the opening ceremony, it's not just presenting your research findings, but the skills. Professor Newton has said it today, the skills that you have been able to acquire, the confidence. I'm expecting that those who presented the poster presentation will migrate to oral presentation next year. And then, you know, the awards for the oral presentation I would say they are heavy, more than the poster. But usually the early part of your research, whether MPhil or PhD, can be in a poster. But when you are about to finish or you are in your final stage, I would rather recommend that you push for oral presentation. That will depend on the abstract that you are submitting, because the scientific committee will have to decide. But I'm hoping this conference will be sustained for a long time, and we'll continue to build your capacity through this. It's not only this conference. We do also faculties and schools and even departments. They do also have workshops to build your capacity. What I will encourage you to do is that the key thing is that after your MPhil or your PhD, most of you will end up in the research or academia. But the skills of getting funding, make use of your network and then your supervisors so that you can also attract, whether within the college or university or outside. That will make you more of a scientist that you can do more, because there are a lot of things that we are supposed to do, but sometimes in our resource limited environment we are unable to do. But if you're able to get the necessary funding, as for the brains, we are maybe I can say we are better than them, but they have the resources. Yesterday I received a video from one of our former students. He did the MPhil in pharmaceutical chemistry. He used to be one of my pharmacists and then a former student of mine, Kwakuchum, went one of the universities in the top university in the US. He was adjudged as the best PhD, the best thesis when it comes to the doctoral level. And I was so happy. When they were even struggling to mention the name. So that is what we want you to achieve. I've recommended or urged the chair of the planning committee to engage the editor-in-chief of the JAST, that is a KNUST Journal of Science and Technology, whether we can have a special issue where your abstract can be captured as conference proceeding. That one, it will be one of the publications that the director of graduate school indicated that is coming. So we'll engage and see whether it can be done. If it's supposed to be done, and some of you may be requested to do one or two things concerning your abstract, I think don't hesitate to do that, so that it will serve as a means of not just this forum, but to other scientists who can take advantage of your research findings. I appreciate the work, my fantastic planning committee chair. I don't know, since they started, I believe, Prof, you've not been sleeping. I do a lot, but I realize that maybe he's doing more than what some of us we've been doing. And the results that we've been getting, I think, Prof, I think you and your team need an applause for what. And he has been doing it since we started this last year. And we hope that, Prof, you will continue to support you and your team. As for the winning team, we are not prepared to change. Maybe when I exit office, and then, but we also appreciate the graduate students. If it wasn't you presenting abstracts, then I think we will not be here. But the motivation, as I said, is that next year we'll have the same platform. Let's work hard. Those who are about to finish your PhD, your MPhil, work hard in such a way that you can have something to present. And then we'll also make sure that as for the graduation rate, the director of graduate school indicated that we are doing so well. So the rest is on you. We are on our supervisors to make sure that you complete on time. And then if there are opportunities, we can also assess. I wish you well in whatever you'll be doing. And then, God willing, we meet next year. Those who are graduating, don't leave us. When you go, you can even join the conference. Thank you very much.
A round of applause for the provost. Thank you very much. We would like to have the final words from Professor Alexander Debra, the conference chair. Please, a round of applause.
Thank you very much. Normally, in our part of the world, when the chief speaks, the servants are not supposed to speak again. Provost has spoken. So I'm not allowed to say anything further, except to acknowledge some people. Even though I know there will be vote of thanks, Provost, first of all, I want to thank our senior members. Since yesterday, some have sat in from morning till evening, and even up to now. Typical example is our judges. They've been here since yesterday. We thank them very much. And then we thank our award sponsors. Some of them are retirees, and they dug their hands into their pockets, bring out money to motivate young ones. In fact, you can't find this anywhere except College of Health Sciences. So please, let's once again give it to them. Provost, I just talk about sustainability, which is very important. We, as a college, we need to think of how we can sustain this conference. Last year, we spent about 130,000 cedis, which was sponsored by the provost, and then we had some sponsorship. I said it in my opening address. This year, we budgeted for 200,000 Ghana cedis. The provost gave us more than 103,000 cedis. The rest, we got it from sponsorship, from principal investigators and other corporate entities. The question is, how can we go on soliciting for money for conferences? Most often, when we attend conference, we pay. Sometimes in dollars, in euros, hard currency, yet we are eager to pay and go. So the question is, if even our senior citizens, retirees, are digging their hands into their pocket to support this conference, we, the graduate students, what can we do to help? I haven't discussed this with the provost, but it's a conversation that we will start. How best do we sustain this conference? It has time to stay. As I said in my address yesterday, last year we had 84 abstracts. This year we had 165, which means students appreciate the conference. Therefore, we need to find a way of sustaining it. And again, yesterday, the Dean of Graduate School said, we could use this as publication. You need to submit 2 papers before you can submit your thesis as a PhD student or candidate. And if you can use this as one of them, it means the other one, it becomes cuckoo. Therefore, if this is a platform for you to actually submit your thesis, then we need to think of how best we can sustain it. So we will start having conversation with the executives of GRASAC so that we see how best. I mean, I can see now your face has changed, but that's the reality. It might not take place next year, but certainly at a point it has to take place where we all have to contribute from the participant, from the college, from sponsors, etc. So on that note, I'd like to thank you very much. And Provost, I think next year we institute another award. This year I saw 4 people with babies at their back, participating in the conference. So next year there'll be another award for those who come with their babies. If double people are winning, the best rap, award, then those with babies can also win. So next year we institute another award for those who come with their babies. On that note, thank you very much, and I wish you all the best.
Thank you very much to the chair of the conference committee. We are very grateful. He's done so much. Please, let's give him a round of applause. We're going to have the final thanks. So many thanks have been given. We would like to welcome Dr. Ijeoma Enyite Koko to give us the vote of thanks from the Department of Imaging. Okay. Please, we would like to have all the planning committee members come up front. All planning committee members. All planning committee members. They are busily planning. Please, a round of applause for all of them. Please, they are still coming. Let's clap for them. We have those in the scientific committee, logistics and protocol, finance and publicity. Please, let's welcome them. We would like to specially acknowledge their contribution and for making this program a wonderful one. So they will stand as we receive the vote of thanks, because she's doing that on behalf of the entire team.
Okay, so I guess this is my cue. On behalf of the organizing committee for this year's, the second Postgraduate Conference, I would like to say a very, very warm thank you to all of you, most especially first to our provost for gracing the occasion for his brainchild, for supporting it, and for also being here throughout the conference to make sure that it went on well. I thank all the distinguished professors who have been here, who have taken time to be here, to participate, to share their insight. But a special thank you to our planning committee. They have been wonderful. This occasion has been so well organized, so seamlessly put together, and I think we all benefited greatly from whatever we came to do here. We also want to thank in a special way every single participant, those that submitted their abstracts, whether they were accepted or not, those that actually did their presentations. We thank you for your insights, for showing and sharing the wonderful work you're doing, for even the hard work you've been putting into your postgraduate research. It's fantastic to see what everybody is doing, and I'm sure that next year and the years to come, it will be better and greater. I want to also thank everybody here present now. You have been so patient. The day is far spent, but the room is not empty. Thank you for your patience and your time. We're extremely grateful to all of you. So thank you very much for being here, and we thank God for a wonderful program.
Oh, thank you so much for thanking us. Please, what do we have to say to the planning committee? God richly bless you. Please have your seats as we welcome Reverend Lauren Salah to give us the closing prayer. Please, if you've not registered, make sure you register. And the good news is that all those who received awards will receive mentorship from the respective sponsors. Please, let's applaud this.
Thank you very much, Princess, the only princess in the college. May we please be on our feet to give thanks. Our Heavenly Father, we are grateful. We are thankful for making this program possible. We thank you for your presence throughout this program, the second of such. We pray for many more. We pray for your presence. Father,